So I am going to speak today about the injuries around the elbow joint. Before this, we have already completed the injuries around the shoulder and the fracture and the humerus bone fracture also. So आगे आ जाओ. Come on the front side. Why are you making a crowd on the back benches? Last 3 lines are overcrowded and first 3 lines are just lying vacant. आगे आ जाओ भाई. Don't go on the back side. And last benches, please don't make noise. So we'll first discuss about the relevant anatomy pertaining to elbow, so that we can better understand what is an elbow joint is like, what are the common injuries, how they happen, how the mechanical forces cause certain type of fractures, and how can we correct the displacements and treat these fractures. And then there are many fractures around the elbow joint. So today I will be only telling you about the supracondylar fractures of the humerus. So as regards the relevant anatomy, as you know, the humerus, the diaphysis, is a cylindrical bone, and at the lower end it just gets flattened, it flares up, and it consists of then 2 condyles, a lateral condyle and a medial condyle. Now a lateral condyle of the humerus consists of an epicondyle, lateral epicondyle, and capitulum of the humerus, while the medial condyle consists of medial epicondyle and a stool-shaped structure, which is the trochlea. Now an elbow joint consists of lower end of the humerus, the upper end of the ulna, and the upper end of the radius, and this is basically a hinge joint, which means the movement is around a particular axis only. So only flexion and extension movement is possible at the elbow joint. That is why it is called a hinge joint. The proper elbow joint is basically ulno-humeral joint. Then there are 2 other small joints, the radio-capital joint, the head of the radius articulating with the capitulum, and the radial head also articulating with the upper end of the ulna on its lateral aspect. This is superior radio-ulnar joint. So this trochlea, this spool-shaped structure, gets accommodated in the upper end of the ulna, which is the trochlear notch, and that is coronoid process on the front of the ulna, and this goes to engage into the coronoid fossa, which is lying anteriorly in the distal humerus, while the olecranon process articulates with the olecranon fossa, which is on the back side of the distal humerus. Then you must remember that this lateral epicondyle is continuous with the lateral supracondylar ridge, and the medial epicondyle with the medial supracondylar ridge. So what are the important attachments around the elbow joint? The common flexor origin takes place from medial epicondyle, and similarly the common extensor origin takes place from the lateral epicondyle. The median nerve is passing on the front of the distal humerus, little on the ulnar side. The ulnar nerve is also very close. It is passing behind the medial epicondyle, and the radial nerve is of course passing from posterior to anterior side on the lateral aspect. Then the elbow joint is how does the stability of the elbow joint comes from? It comes from the bony articulation, the spool-shaped structure of the trochlea and the olecranon notch. So the bony configuration itself provides stability to the elbow joint, not easy to dislocate. The ligamental stability comes from the two collateral ligaments, the medial collateral ligament and the lateral collateral ligament. Then you have an annular ligament just below the head of the radius, which is attached to the ulna. Now this annular ligament is preventing any radial head displacements. As we commonly seen in children, the radial head is comparatively small and the annular ligament is rather lax. So what happens in children is that when we pull the children after catching their forearms, this radial head easily gets displaced, which is called a pulled elbow condition. This is the radial tuberosity, a rough area on the lateral side of the upper end of the radius, to which is attached the tendon of biceps, which is the main flexor of the elbow joint. Similarly, on the coronoid process is attached the insertion of brachialis, which is again a flexor of the elbow. On the olecranon, posteriorly is attached the tendon of triceps, which is mainly the extensor of the elbow. So this is trochlea, which is on the medial side of the distal humerus, capitulum lying on the lateral side, that is the medial epicondyle, lateral epicondyle, lateral. So this is the AP view, where we see this fossa is coronoid fossa, where the coronoid process of the ulna is articulating, and posteriorly there is olecranon fossa, where the olecranon is engaging. So this area of the distal humerus is quite weak. It is a flattened thin plate of the bone, and it is through this area that the fracture quite commonly happen, which is the supracondylar fracture. It takes place just here, just above the epicondyle, just above the medial and lateral epicondyles is the supracondylar area. So this is the lateral view. The distal end is a little bent anteriorly. This is the from one side view, this is the other side view. So proximal ulna, everything is obvious. Olecranon, coronoid process. This is the trochlear notch, where the spool of the trochlear spool is articulating with the ulna, and that is the radial notch where the radial head is articulating, and as you pronate and supinate your forearm, this radial head is moving along this sulcus. So this is proximal radius, that is the radial head, which is articulating on the medial side with the ulna, that is the neck, where there is annular ligament which controls the subluxation of the radial head, and that is radial tuberosity facing anteromedially, where the tendon of the biceps muscle is attached. So once you get an injury of the elbow, the most common investigation is X-ray of the elbow. You always get the X-ray in two views, AP and lateral, because certain displacements only you see in the AP view, while other displacements you see in the lateral view. So what you see in A lateral view is anterior or posterior displacement, and in the AP view you can see the medial or the lateral displacement. So in this X-ray what you see is humerus, lower end of the humerus, that is the olecranon fossa, ulna, radial head. And do you see any fractures? Yes. How many fractures? One, two, or three? Any one of you who doesn't see a fracture? Raise your hand. Is there anyone who says there is no fracture? So all agree there is fracture. 1, 2, and 3. Right? Yes? Wrong. There is no fracture. Then what is this? This is physis. So now how to differentiate whether it is a physis or a fracture? So there is a saying, your eyes don't see what your brain doesn't know. Okay? So if you don't know what is epiphysis, for you these are fractures. So it is important to remember what are the different epiphyses. And as we know that the child is particularly this year of age, where do we expect to see the epiphysis? So definitely these are epiphyses and not the fractures. So coming to the ossification around the elbow joint, if you are suspecting any injury, you get 2 X-rays done, AP lateral. Then you imply your knowledge on the X-rays whether it is an epiphysis or it could be a fracture. And if it is still confusing, then you have the normal elbow of the opposite side. You can always take that X-ray and compare the two views. So to remember, there are so many epiphyses around the elbow. 1, 2, 3, 4, 5, 6. So there is an easy formula to remember, and that is Critol, C-R-I. I will take as internal epicondyle, T-O-L, lateral epicondyle. 1, 3, 5, 7, 9 and 11 years. So first we see the capital lump. So this ossifies at the age of 1 year. Radial head at 3 years. Medial epicondyle at 5 years. Trochlea at 7 years. And external epicondyle at 11 years. And roughly around 20 years of age, they all fuse. So second important thing around the elbow joint is the 3-point bony relationships. These are the 3 bony points which you can feel for yourself in your elbow. Medial epicondyle, lateral epicondyle, and the tip of the olecranon. So they have a particular relationship. If you hold your elbow at 90 degrees, they will make a triangle. If you extend your elbow fully and then you palpate these 3 bony points, they will fall in a straight line. So this triangle during 90 degree of the flexion of the elbow they form an isosceles triangle. What is an isosceles triangle? Yeah, and the 2 sides of the 3 lines are almost, so it is not a complete ideal isosceles, but it is near to an isosceles. Almost 2 sides are equal. The base is formed by a line joining the 2 epicondyles. So what is the significance of this? If you get a dislocation of the elbow, the humerus will go anteriorly and probably the olecranon will go posteriorly, and all this normal relationship will be lost. But if you have got an injury where all these 3 bony prominents are not disturbed, they make a triangle in flexion and a straight line in full extension, that would mean that the if they are disturbed, that would mean the injury is somewhere in between these 3 points. So it could be intra-articular fracture. Okay. So another important thing to remember is about the carrying angle. What is carrying angle? You draw a straight line along the axis of the arm, and another line is drawn along the axis of the forearm. When these two are joined, they form an angle. Normally you would imagine that it would be in a straight line, but the arm and forearm axes are not in straight line. The forearm forms roughly an angle of 11 degrees in males, and this is slightly more in females, that is 14 degrees. So that is the long axis of the arm, forearm. But if it is too much deviated, then it will be called a cubitus, means elbow. It is cubitus valgus. And if it is neutral or on the negative side, then it is cubitus varus. So it is important when we are examining an elbow case to know whether there is a normal carrying angle or whether it is lessened, that is cubitus varus, or whether it is increased, it is cubitus valgus. So I'll now talk about supracondylar fracture of the humerus, although there are many other fractures like lateral condyle fractures, the medial condyle fractures, or medial epicondyle fractures, and the dislocations of the elbow that we'll take up in the next class. So this X-ray here you see, this is a fracture. Obviously this is not a fracture, this is an epiphysis. The fracture is somewhere here. In the radial head also you see the epiphyseal line. It is not a fracture. So how do the injuries around the elbow take place? There may be either a direct injury, that means any lathi blow or something stick which you are hit around the elbow itself. You can get a fracture of the olecranon or condyle fracture. Or most commonly the mode of injuries fall on the outstretched hand, which is also called the foosh, F-O-O-S-H. So the elbow is forced into hyperextension when the hand strikes the ground. Like this child on this board trips, resulting in a fall. Automatically the hand stretches out, the elbow gets into extension, and the child lands on the palm of the hand, resulting in hyperextension of the elbow. So this is the most common injury. What is the pathoanatomy of the supracondylar fracture? The fracture line runs horizontally above the condyles. As I told you, this is I can't make out which is the side. I mean, it is above the epicondyles, supracondylar fracture through the olecranon fossa. Shift on one side, shifts posteriorly. So the most common displacements are posterior shift. This is a lateral view, anterior side, posterior side. So this fracture is displaced posteriorly. It is also tilted posteriorly. That means it is making an angulation. It gets a tilt on the posterior side. Proximal shift, the fragment rides high, there is shortening, that is the proximal shift. Medial or lateral shift. Shift is the whole fragment shifting medially or laterally, and the tilt is making an angulation. It can tilt medially or it can tilt laterally. And lastly, the internal rotation, the whole fragment is rotated internally. And as we know from our knowledge, we can depict, we can find out on X-ray about the shifts, tilts, but rotation deformity cannot be assessed on the X-ray. So what are the clinical features? You will obviously get a history of trauma by fall. Patient would complain of pain around the elbow. There will be a lot of swelling and elbow would look deformed, and because of the pain, intense pain, patient will not be able to move the elbow. So as you can see in the X-ray, there is posterior shift, there is proximal shift, there is medial shift and medial angulation. On examination, because the whole the supracondylar part of the humerus is shifted posteriorly, there is posterior shift, you will find there is unusual posterior prominence of the elbow, as you can see in this diagram. Diffuse swelling. If you examine the joint, it is extremely tender. You will not be able to, although theoretically we know there are three different bony points, medial, lateral, epicondyle and the olecranon, but practically speaking, when you get a supracondylar fracture in a child, he will not allow you to examine properly. You will not be able to identify these bony landmarks. However, if you are able to somehow palpate, then these the 3-point relationship will not be disturbed in supracondylar fractures. Radial and ulnar pulses may be absent with or without signs of ischemia. Now, this is because if the fracture is severely displaced, there may be compression on the brachial artery and you may not be able to get the radial and the ulnar pulsations. Also, anteriorly you get the median nerve. The proximal fragment may just push around the median nerve, can compress it, resulting in neuropexia, and so you can get a median nerve injury, and rarely radial nerve injury you can get. And we have already learnt about the nerve injuries. The diagnostic feature of the median nerve injury is a pointing index sign, and that of the radial nerve injury is the wrist drop. Then we get an X-ray done. Now, as we looked around in the previous X-rays where we were discussing about the various epiphyses, if the fracture is not displaced, it's a minor fracture, you can just miss it. But there are certain subtle signs like fat pad signs, I'm not going to tell them in detail, by which you can suspect there is supracondylar fracture. However, if it is a grossly displaced fracture, then you cannot miss it. It is obvious on the X-rays. Here you see this is a posteriorly displaced shortening. You can't make out the rotation, you can't make out the medial or the lateral tilt. So basically, supracondylar fracture, depending upon their displacement, are treated. If it is an undisplaced fracture, there is no displacement, then simply you immobilize the arm in an above elbow plaster with the elbow in 90-degree flexion till the fracture heals. Usually it takes 21 days or 3 weeks of time for the fracture to heal, and it is advisable not to prolong the immobilization, because then it can lead to complication of stiffness around the elbow. But if the fracture is not displaced, now whether it is displaced or not displaced, supracondylar fracture we classify into 3 types. Type 1, not displaced. Type 2, displaced, but there is some posterior cortical hinge maintained, continuity is maintained. And type 3 is a complete displacement. This is type 3. There is a total displacement of the fracture. Type 3. However, if this fragment would have been here with only a little angulation, it would have made it a type 2 fracture. And if you would only see a fracture line without any displacement, that would make a type 1 fracture. So type 1 fracture treatment, simple, POP slab for 3 weeks. Type 2 and type 3 would of course require reduction. You have to reduce the fracture. So supracorneal fracture in children is rather considered as an emergency, because if the treatment or the reduction is delayed, then it may not be possible for us to get a close reduction. So we try to reduce it as early as possible. That is number one. Number two, small children, often there may be a arterial neurological complication which the child may not tell, and if it is not treated soon, then these complications become very serious. So first of the method is that mostly these, whether it is a type 2 fracture or whether it is a type 3 complete displaced fractures, our first attempt is to do a close reduction and percutaneous K-wire fixation system. What do you understand by close reduction and K-wire fixation? The other is open reduction and K-wire fixation. So what is the difference? Open reduction would mean that you open up the fracture in the operation theatre, and then under your vision you reduce it. While in close reduction means you just manipulate the fragment, just like a Pehlwan does. We do a close reduction and do a K-wire fixation. How is it done? Because in operation theatre we have a C-arm image intensifier machine, which you can say is a X-ray screening machine. So not without much radiation, we manipulate the limb, the joint. We look in the X-rays whether the fracture is reduced or not. If it gets reduced, then without making elaborate incision and exposing the bone, we push in the wires and put in the wires in such a way under C-arm image intensifier that these wires engage the bone and fix the fractures. So that is what is close reduction, and percutaneous means through the skin we are inserting the wires, but the wires are going into the bone. We have not made any incision, just a small nick we can make. We put in the wire and it goes across the bone. So supracorneal fractures can be easily reduced, but they tend to slip back. Why do we do K-wiring? Because if we have done a close reduction by manipulation and we apply a plaster, then if the plaster may get loose, and even if the plaster doesn't get loose, there is a natural tendency for the fractures to slip back into its originally deformed position. We don't want that to happen. So to control that, we want to fix it using K-wires. So once the K-wires are done, so how do we reduce the fracture? That is important. Under anesthesia, we take the patient under general anesthesia, elbow is taken into 30 to 40 degrees of flexion position and then traction is given. How the traction is given? The surgeon pulls on the forearm while the assistant pulls back on the arm. So a traction is applied. So this traction is applied initially in 30 to 40 degrees of flexion. Then elbow is gently fully extended. So from this position it is fully extended and supinated. This is supination, this is pronation. So it is fully supinated. So what does this maneuver does? By traction and counter traction, whatever shifting of the distal fragment has been there, proximal shifting, it comes back to the position. The length is regained. And then we manipulate the elbow. If there is any medial or lateral shift, this is corrected, either by manipulation or by the traction alone. These displacements get corrected. So after a continuous traction for 2 to 3 minutes, the olecranon is then pushed forwards into flexion. With our thumb we push back on the olecranon, push it anteriorly. So whatever posterior displacement has been there on the fragment, that gets corrected. So olecranon is pushed forward into flexion as the elbow is flexed beyond 90 degrees. The elbow is flexed beyond 90. And this is the position where the fragments get locked. Now under C-arm image intensifier, fracture is fixed with percutaneous K-wires in this position, and the slab is given for 3 to 4 weeks. So you can see this fracture is reduced. One of the wire is passed here from the medial side through the medial epicondyle into the main fragment, into the proximal fragment. From the lateral side, the wires pass through the lateral condyle across the fracture into the proximal fragment. So these wires are now holding the fracture and they are not allowing the fracture to redisplace. So open reduction may sometimes be done when fracture cannot be reduced by closed methods. It is also indicated in open fractures. What are open fractures? No, not hematoma. As opposed to closed fracture which have no wound. Open fracture is when there is a laceration on the skin, when there is an open wound. And why open fractures are more grave, more serious? Because we presume that the fracture has been exposed to the external environment and it is potentially infected. So once there is an open fracture, we only need to require to enlarge the wound and see the bone fragments ourselves. So in open fractures we do open reduction and internal fixation. Again in this condition we do open reduction and fracture is fixed with K wire. So basically it is the K wire which are used to fix the fractures. Now we come to the complications. Now depending upon what are the complications and when they are likely to take place, we have grouped them into three. Immediate, that means fracture has opened today, so these complications may be there immediately, or by the evening we can identify that this is the complication and we should treat them accordingly on an emergency basis. Then early, these complications are the ones which present within 3 days of the injury, and late complications which present after a few weeks or few months of the fracture. So the immediate complications are two: injury to brachial artery and injury to the nerves. So most commonly injured nerve is the median nerve. This median nerve is coming along close to the brachial artery over the anterior side, and as I told you, the fracture fragment can impale into the median nerve. And what is the diagnostic sign? Pointing index finger, that is the sign. So besides, you always examine the patient. If he can flex the fingers, then that means there is no median nerve injury. Radial nerve injury can be there because the radial nerve is passing from the posterior side over the lateral, comes on to the lateral side and then on to the anteriorly over this part of the humerus. So just look for the dropped wrist sign, wrist drop sign. If it is not there, that means radial nerve is injured. So coming to the injury to the brachial artery. Brachial artery can be injured by displaced sharp fracture ends over here. It may lead to minor injury to a complete disruption. Either there may be some contusion over the arterial wall, or the injury, there may be complete laceration of the brachial artery. So this can result in ischemia of the flexor muscles and eventually Volkmann's ischemia or complete gangrene of the forearm. It is a complete brachial artery, not identified in time, not proper measurements are not taken immediately, then this can result in the gangrene of the forearm. Or if there is a minor injury of the brachial artery, not identified immediately, can lead to ischemia of the flexor muscles of the forearm, which eventually leads to Volkmann's ischemia. So we'll discuss later what is Volkmann's ischemia. So Volkmann's ischemia is an ischemic injury to the muscles and nerves of the flexor compartment of the forearm due to occlusion of the brachial artery by a supracondylar fracture. So when the child comes to you, you look for the radial and the ulnar pulses. They may be there, they may not be there. Even if they are palpable, you should always look for the signs of the Volkmann's ischemia, because there may not be a proper flow through the brachial artery, and this might be causing the ischemia of the flexor muscles of the forearm. So what are the clinical features of the Volkmann's ischemia? Severe pain in the forearm over the flexor aspect. Unable to move fingers freely. He will not be able to extend, especially because there is ischemia of the flexor muscles. So as soon if you passively extend the fingers, this will result in severe pain. And of course there will be forearm tenderness. There are actually 6 P's which identify Volkmann's ischemia or the compartment syndrome. One is pulselessness, pallor, paralysis, paresthesia. So these are the signs for Volkmann's ischemia. And if you diagnose these Volkmann's ischemia, the treatment is urgent, because if it is not treated properly, then the muscles can undergo a complete necrosis and fibrosis. So once you have diagnosed it, just look for any external splints and bandages. They might be tight, because someone who has treated a supracondylar fracture by applying a splint or a bandage, that might get tight, and if it is tight, this is causing further ischemia of the flexor muscles. So first of all, look for the external bandaging. Open up all the tight bandages. Forearm is elevated so that you allow venous drainage, and fasciotomy is done if no improvement in 2 hours, and you decompress the compartment. What is fasciotomy? So basically the flexor muscles are in a closed compartment, tight osteofascial compartment. There are bones, the radius and the ulna and fascia, which is attached to the borders of these bones. So this makes a closed compartment. So when there is ischemia of these muscles, ischemia results in swelling. Swelling results in increase in the volume of the compartment. Increase in the volume of the compartment will lead to capillary blockage of venous drainage, and it will further increase the swelling. And if the swelling is allowed to continue, then it will lead to ischemic necrosis. So you have to release them. So you divide the fascia. That is called fasciotomy. That is the only way by which you can release a tight compartment. So this is an urgent operation required in Volkmann's ischemia. Okay. So coming to the late complication, the most common late complication is the malunion. So what is malunion? When the fracture fragment has not united in an acceptable position. Almost all supracondylar fractures will unite. There will not be hardly any non-union. But if you have not properly reduced it, then this leads to malunion. Fracture unites with distal fragment tilted medially. That is the most common position. The distal fragment is tilted medially and internally rotated, and it results in cubitus varus deformity. That is the most common deformity, also known as the gun stock deformity. Now this is a cosmetic problem, mild functional impairment. Severe deformities are treated with supracondylar correctostomy. So this cubitus varus deformity is like a gun stock deformity, as is depicted in this diagram. And more or less there is no functional impairment. The child is able to perform every single movement that is required. The only thing is cosmetically it looks bad. So usually these fractures are taking place between 3 to 10 years of age. So supposing the child has suffered this fracture at 4 years of age, and you have reduced it, even if you have done a closed reduction or open reduction with KY section, still some of these cases will lead to cosmetic deformities. The parents will bring this child to you complaining of that he has got a disability, although he has no functional impairment. He is able to do all his routine work. For this functional deformity, we advise operation, but say the child is of 5 years of age, 1 year back he had suffered the fracture, and if at this stage you do a corrective osteotomy somehow and you correct the deformity, then it is likely that with the future growth in the child, the deformity can recur. So what we tend to do is, when the child is nearing skeletal maturity, at that time we want to do the corrective osteotomy so that the chances of recurrence of deformity are less. Another late complication is the myositis ossificans. Myositis ossificans is ectopic new bone formation. Ectopic means outside the bone. It is not in its natural place where this bone is forming. And myositis ossification is a complication where the bone or the calcium phosphate crystals are deposited around the fracture site, but in the muscles, most commonly the brachialis muscle anteriorly. So this complication takes place in those children especially who are treated with massage by Pahalwans. So they do massage. The massage results in more of muscle injury around the elbow. They massage the elbow, the brachialis muscle gets more of hematoma, and there are more chances of the hematoma getting ossified. So this ectopic new bone formation is associated with the history of massage in children. This results in stiffness of the elbow. Massage of the fracture is mostly responsible for it. So it is in actually 3 stages. First is the acute phase, when there is hematoma, when the bone is forming in the hematoma, in the muscle mass, it is acutely painful. And the second stage is the tumorous stage, where the child sees an obvious mass, hard mass is forming around the elbow. And third is the resolving phase. So I can't see clearly, probably this is the first stage. This is the second stage, where there is a formation of a mass. You can easily, clinically it is easily seen, palpable, hard mass, and you can confuse it whether it's a tumor or not. However, if the biopsy is done, that can make the differential diagnosis, because if you see on the X-ray, you still see that there is a growth of the bone. So you have to differentiate it whether it is myositis ossificans or there is some neoplasm. And then third is the resolving stage. After a few months, this extra bone gradually gets resolved, well formed. And if after a few months still there is some bump over there over the bone which is causing restriction of the movement, then you can plan for a excision of this myositis ossificans. And if there is extensive bone formation around the elbow joint which is restricting all kind of movements, then you can do an excision arthroplasty. Then Volkmann's ischemia we discussed. If the Volkmann's ischemia is not treated in time, it is not treated effectively, then it can result in Volkmann's ischemic contracture. This is a sequel of Volkmann's ischemia or compartment syndrome. Here there is fibrosis of the forearm muscles, and the muscle mass is replaced by the fibrous tissue. And as you all know, the muscle is contractile, it is flexible, the fibrous tissue is tough, it gets contracted, it is not expansile. So what you get is a contracture of the forearm muscles. And since it is in the flexor group of muscles, all your flexors become very short. Sometimes you also get sensory or motor deficit because there is a nerve injury because of the ischemia during the phase of the compartment syndrome. So what are the clinical features? There is marked atrophy of the forearm, as you can see, no muscle mass on the flexor aspect, flexion deformity of the wrist and fingers, and there is Volkmann sign, extension of fingers possible on wrist flexion, because their total contracture of the flexor muscles, both are getting flexed. But if you flex the wrist, then you are able to get the extension into the fingers. But if you have extended the wrist, then the fingers cannot be extended. So this is Volkmann's sign, which is diagnostic for the VIC. How do you treat it? There are splints. This is the way they are applied. The fingers are kept extended, and the wrist also is gradually thrust into extension using a mechanical lever application onto the splint. So you gradually stretch the soft tissues. For medium deformity, soft tissue sliding surgery is performed. The flexor muscles which are contracted from their origin, an operation is done where they are slided, their origin is released, and therefore this contracture gets released. And in very severe deformities, what you do is you shorten the forearm bones. Radius and ulna both are shortened by an inch. Therefore, you get a functional length of the forearm muscles so that you can extend the wrist, you can extend the fingers. So that was all about it. If you have any questions,